think I'm going to get started in the interest of time. I know we've been trying to start on time. I'm Sarah Lubitz. This is the third time we're doing this. Definitely please reach out if you have questions or concerns. I see. And Dr. Shamash is getting on right now, but I'm
yes,
okay. Just saying hi again.
My apologies for being a couple minutes behind. Yes, I want to reintroduce Dr. Sarah Lubitz, our endocrinologist from Robert Wood Johnson, who's done a great job speaking to us about pituitary and adrenal disorders in part one. Part two, we had an excellent discussion of thyroid, if I'm not mistaken, and I'm trying to remember the other things we spoke about. And today we'll have session number 3. And very much looking forward to it, Dr. Lubitz. Thank you.
Great. Thank you so much. Okay, so this is my proverbial diabetes obesity slide. I know it's an old one, but right, nobody gives a talk nowadays without showing one of these CDC prevalent slides. And again, I don't have to tell you how important obesity and diabetes is and rampant and ever increasing in our nation. So let's talk about how to diagnose diabetes. We'll start with a question. So who has diabetes mellitus? Do you think it's A, the 30-year-old obese African-American male with a fasting blood sugar of 105 and an A1C of 6? B, a 57-year-old Caucasian male with renal disease on epoetin alpha injections for anemia with a fasting blood sugar of 130, 134 on the repeat, and the A1C is 4.7? Is it the 67-year-old thin Southeast Asian female with fasting blood sugar of 120, 124 on repeat? And she checks her sugars with her husband's glucometer 2 hours after meals when she feels dizzy and gets readings in the 80s? Or is it the 18-year-old obese Hispanic female with acanthosis, polyuria, and polydipsia, and a random plasma glucose of 188? We'll launch the poll. What do you think? Okay. And so I think I did trick most of you. The right answer is B here. The right answer is B. And I'll kind of go through the diagnostic criteria and what's going on here. So the diagnostic criteria for diagnosis of diabetes, and this is kind of like, it's non-pregnant adults, and you kind of just have to memorize these numbers. So it's fasting sugar above 126. It's a 2-hour glucose greater than 200 on an oral glucose tolerance test. It's an A1C above 6.5, or it's a random sugar above 200 with those classic symptoms of hyperglycemia, polyuria, polydipsia, polyphagia, weight loss, blurry vision. So in the question I had showed you in choice D, the fasting sugar was not above 188. And then we kind of use these categories of pre-diabetes is what we call it. It used to be called, if your fasting sugar was above 100, that would be impaired fasting glucose. If your 2-hour glucose tolerance test was between like 140 and 199, that's impaired glucose tolerance. And if your A1C is between 5.7 and 6.4, and all of these things now we're calling pre-diabetes. And I definitely want to point out that even with the pre-diabetic numbers and the diabetic numbers, certain conditions and underlying things that cause people to have insulin resistance or type 2 diabetes, somebody may be more prone to failing a glucose tolerance test than having abnormal fasting blood sugars. And now in the question I gave you, the person's A1C was normal. And I want to just point out to not fall into this trap because we see it more and more. A1C is really easy, right? It could be done any time of day. You could do it finger stick A1C in the office, point of care testing, somebody comes into the hospital, but it's not going to be accurate in any condition which affects red blood cell turnover or if the patient has a hemoglobinopathy, right? So this glycohemoglobin is formed when the glucose reacts non-enzymatically with the hemoglobin A molecule. So anyone who has an abnormal hemoglobin A molecule, sickle cell, thalassemia, things like that, it's going to have a false hemoglobin A1C level. And also, if you have a lot of brand new red blood cells that have just been kind of born and don't have a lot of sugar stuck on them, such as in anemia, and in the question I gave you, that person was like on erythropoietin alpha, they were on like Epogen. So they're going to have a lot of brand new red blood cells that are being made, not with sugar stuck on them. So all of those conditions will end up causing a false low A1C. So again, just the A1C is easy, but you got to kind of, say, does this person have a normal hemoglobin A molecule? And have all the red blood cells in this person been living the normal red blood cell lifespan, which is about 120 days? Otherwise, the A1C is not an accurate measure of somebody's blood sugar. Or, oh, and I want to totally add, if they have a transfusion, I can't tell you how many times we see that they call us on patients from trauma who have had 6 units of blood and their A1C is normal. It's someone else's A1C. It's not even theirs at that point. Okay, so let's say we had a 68-year-old woman with diabetes for 20 years who's begun to have labile glucose measurements. Originally, she was well controlled on oral drugs, but she now requires basal bolus insulin therapy. She also has a history of Hashimoto's hypothyroidism, and on physical exam, she's thin. An anti-glutamic acid decarboxylase antibody titer is positive. What is the most likely diagnosis in her? Is it A, type 1 diabetes mellitus, 2, type 2 diabetes mellitus, C, the latent autoimmune diabetes of adulthood, the LADA complex, or D, maturity onset diabetes of the young, MODY? What are you thinking? Good, and most of you got this right. The correct answer here is C, latent autoimmune diabetes of adulthood, LADA. So let's talk about these different types of diabetes. So type 1, as you know, it's an immune attack on the beta cells themselves, and they usually have positive antibodies. The most specific one is that glutamic acid decarboxylase antibody, but we also check for anti-insulin antibodies, islet cell associated antigen antibodies. And these patients have an absolute insulin deficiency. They need insulin at all times, otherwise they can go into DKA. And 20% of them will have other autoimmune diseases. And the age of onset is usually childhood or adolescence for pure type 1 autoimmune diabetes. Versus type 2 is more of this very complicated pathophysiologic disorder. And every time, the more people study it, the more we find it has like very little to do with the pancreas. And we know that the pancreatic beta cells have decreased insulin secretion, similar to type 1, but there's so much else going on, causing this insulin resistance and the hyperglycemia and relative insulin deficiency. The muscle doesn't take up glucose properly. The liver is doing something where at night while you're sleeping, when you don't need extra sugar, especially if the blood sugar is high in somebody with type 2 diabetes, the liver is still causing endogenous glucose secretion. The adipose tissue is making lots of free fatty acids, which also then get into the liver and clog up the liver. There's decreased incretin effect in the digestive tract, so that when food hits the digestive tract, in somebody without type 2 diabetes, the incretin system is set off and it tells your brain that you're full, and it stimulates insulin release and decreases glucagon release. And this is not happening in patients with type 2 diabetes. There's increased glucagon secretion. The kidneys are like the new diabetes organ, right? Because everyone knows about the SGLT2 inhibitors, and we're finding that you should pee out sugar every single day. And in somebody without diabetes, if your sugar goes above 200, you're supposed to pee out that extra sugar. But there's something going on in type 2 diabetes where the kidneys are actually increasing the amount of glucose reabsorption. And your sugar has to be even higher to cause you to pee out the sugar. There's something on the nervous system centrally in the brain. This is what people are studying now. The new big diabetes organ is the brain, and how that's causing type 2 diabetes. And then there's these other diabetes syndromes, like what I was asking about. So the latent autoimmune diabetes of adulthood. And so this is usually older, lean patients who don't appear very insulin resistant, and they have the autoimmune antibody markers that are present. And it is an autoimmune disease in that there's this gradual autoimmune destruction of the beta cells, which eventually results in an absolute insulin deficiency, similar to type 1 diabetes. And as I said, because it's autoimmune, they'll often present with other autoimmune endocrine disorders. And it's like type 1 diabetes, but diagnosed over a much slower period of time until they actually may need insulin, and in older adults. Then there's the maturity onset diabetes of the young. And what this is it's an autosomal dominant inherited condition caused by mutations in a single gene that's responsible for the beta cell to release insulin. And in a lot of the MODIs, like MODI 1, 3, and 4, they tend to be really responsive to sulfonylureas, and they don't really need insulin. You could just use sulfonylureas. So that's the important thing to know about that type of diabetes. A lot of patients are misdiagnosed with type 1 diabetes who have these Modi syndromes. And again, they don't necessarily need to be on insulin, and they could be treated just with sulfonylureas. We know lipodystrophy and inherited lipodystrophies, and the lipodystrophy that happens acquired with a lot of the HIV medications cause defects in insulin action. And then you can have diseases that affect your pancreas, such as cystic fibrosis, hemochromatosis, and just recurrent pancreatitis can also lead to decreased beta cell action. We'll talk a little bit later about gestational diabetes, but it typically resolves after birth, but can recur with other pregnancies. And then there's a bunch of endocrinopathies that lead to diabetes syndromes. Acromegaly, the IGF-1 and the growth hormone that are high cause an insulin resistance syndrome. Cushing's syndrome, the high cortisol level leads to a diabetic type 2 type syndrome, and pheochromocytoma can also raise blood sugar. I know you've all seen, especially now around the time of COVID and people coming into the hospital, stress hyperglycemia, just the body's natural response to stress, physical or emotional, raises the blood sugar. And then the drug-induced diabetes. Steroids can temporarily increase blood sugars, but steroids can also induce a steroid-induced diabetes. I think at some point it just uses up the insulin that's left in the pancreas, and people develop a steroid-induced diabetes. Other drugs that can raise blood sugars, thiazide diuretics, beta blockers, niacins, statins. The big statin trials showed that can push people over the edge from pre-diabetes into diabetes. The risk is still not outweighing the benefit of preventing cardiovascular disease, but it is true that statins can definitely raise blood sugar. And we're seeing so much the immune checkpoint inhibitor condition. So there's immune checkpoint inhibitor diabetes mellitus. It's often like a dramatic hyperglycemia, like the person was fine, and then 3 days later, they have this severe insulin deficiency. It's like a type 1 diabetes. And it's commonly seen with the PD-1 and PD-1 ligand inhibitors, not the other immune checkpoint inhibitors as much, but something to look out for. So who do we, test for diabetes? Who do we screen, like in the first question I showed you? And from like ADA has guidelines and ACE has guidelines, but basically it's a lot of people who we're seeing in our daily lives. Age over 45, anyone with a family history of type 2 diabetes, again, which is so common, anyone who's overweight or obese, all these other risk factors on medications that increase the risk of diabetes, obstructive sleep apnea, people who have shift workers are at increased risk for diabetes, all of these things, hyperlipidemia, hypertension. So again, a lot of people coming into your office meet criteria for being screened for type 2 diabetes. So one of the first things that we see and we can find is signs of insulin resistance, like this acanthosis nigricans. And it's that velvety hyperpigmentation at the back of the neck, under the arms, and in inner thighs. Now, these pictures that I'm showing you on like this, textbook type pictures, it's so dark, it's so obvious. You can see that this is acanthosis. And by the time people diagnose diabetes, you're going to see this. But my 14-year-old has acanthosis for sure, and he's had it since he was 11 years old. And I have a very strong family history of type 2 diabetes, heart disease, obesity, and my 14-year-old is on that path, unfortunately, even though like his mom's an endocrinologist. But again, you can really look at people and see just the subtle markings at the back of their neck of acanthosis, and this can be your opportunity. And again, in my clinic, I see young women for thyroid, and when I notice acanthosis, I'll say, hey, does anyone in your family have type 2 diabetes? And usually it's yes, and I can say, I'm starting to see that you're having insulin resistance, you're also at high risk for type 2 diabetes, this means, and this is where you can make a difference and prevent the progression of the disease. But, if you look for it, you're going to find it in lots of people who have totally not normal blood sugars, and it indicates that they do have an insulin resistance syndrome. So speaking about the insulin resistance syndrome, this is all part of like the metabolic syndrome. And it was, really hot back maybe in the 90s. We were talking about like ATP3 came up with these factors, which were the metabolic syndrome, and the diagnosis was established when at least 3 of the criteria were present. It's called Syndrome X, and like they found that it's like about 35% of the US adult population. And we know that having these kind of markers of high triglycerides, low HDL, high blood pressure, high sugar, abdominal obesity, increases your risk of heart disease, increases your risk of type 2 diabetes, associated with PCOS, sleep apnea, fatty liver, kidney disease. And everybody was looking for some magic cure for this insulin resistance syndrome. Is there like one drug or one thing that we can make people do to make it better? And there's kind of not, like weight loss helps with all of it. But basically in the end, after creating a disease and giving it a name, in the end, we talk about that you have to actually treat each individual component of the disease to prevent development of cardiovascular disease. So you have to treat the lipids with a lipid agent. You have to treat the blood pressure with blood pressure agents. You have to treat the sugar with anti-diabetic agents. And so in the end, you're treating all these individual components. So let's talk a little bit about the complications of diabetes. And the worst one, as you know, is diabetic ketoacidosis. And this is, life-threatening metabolic disturbance where the patient has, so in order to diagnose with DKA, they have to have the diabetic part. So they have to have hyperglycemia. They have to have the ketones, positive ketone production, and they have to have a metabolic acidosis. And it's like, right, it's an increased anion gap acidosis. And sometimes there's stuff that fits some of that criteria, but not all of it. And it really is not DKA at that point. And we know that the condition itself is a very dehydrated state. You lose all of your electrolytes, but it's a very total body potassium depleted state. The acidosis just feels terrible. The patient feels terrible. They can develop the Kussmaul respirations, compensatory respiratory alkalosis. There ends up being an uncontrolled lipolysis, so the triglycerides can end up going really high. And as you know, this is kind of one of the conditions that's, we tend to put people in the ICU. They're definitely coming up with protocols. Our ER is one of them where they're trying to treat in the ER, not admitting people, using sub-Q insulin instead of IV insulin to treat DKA. And it's worth a shot, especially if you can hydrate the person and correct the mild DKA right away. But if it looks like it's not being corrected, most of these patients do need more long-term on an IV insulin drip with aggressive fluid resuscitation in a monitored setting, repleting all of the electrolytes. And then the other thing, we'll talk about the treatment, but I want to point out that people don't just go into DKA. Like, so maybe they're non-compliant with their insulin, fine, that's why they're in DKA, or they're new onset type 1. But usually there's something underlying and going on. So you don't ever want to miss, same thing with hyperosmolar non-ketosis, but you don't want to miss what caused this endocrine emergency. So we talked about how these patients with diabetes are at high risk for MI, they're at high risk for infections. You don't want to miss that they have like a UTI or they're having a heart attack. And that's what put them over the edge into DKA if you're just relying on looking at the sugar and correcting the sugar abnormality. One of the things I go over with the residents is these pitfalls of DKA treatment, right? Because everybody knows how to treat the patients, but we always want to remember that potassium supplementation should start once the potassium is like 4.5 to 5, which is high if the patient has normal renal function, because of all the shifts in the acidosis, all the potassium in the body is in kind of the bloodstream at the time that you're checking the levels. So if the potassium is less than 4.5, this person is severely potassium depleted. So you need to think about potassium supplementation right away. And if you remember, if you start insulin, it's going to push that potassium into the cells. So if you're not repleting potassium, you can definitely drop the potassium and drop it quickly and cause an arrhythmia. The other thing is you're not looking to really rapidly correct the sugar. The treatment of DKA is not to normalize the sugar. It's to stop the ketones from forming and the ketones causing acidosis, much more than normalizing the sugar. So the goal, glucose decline, is no more than like 75 to 100 milligrams per deciliter per hour. And in fact, once the sugar starts to go lower, we say to give sugar in order for you to continue giving the insulin, because you don't stop giving insulin until the acidosis is corrected and the person stopped making ketones. So if the sugar is 50, you're in trouble because the person's still in ketoacidosis. You need to give extra sugar. The other thing is people sometimes forget about the calcium, phosphate, and magnesium replacement. Again, this person has a total electrolyte loss with the diuresis. And we've seen people, need ventilator assistance because, you need phosphate to make ATP and to use your respiratory muscles and calcium for, again, respiration and respiratory muscles. You can end up getting in trouble with that. And then the last pitfall I have, which drives me crazy when I'm doing consults, is that everything's good. The person's out of DKA and they're ready to go to the floors, and they turn off the insulin drip and they type in the insulin orders like insulin glargine at bedtime and aspart with meals or something like that. And they forget to overlap the insulin drip. So that insulin drip, the half-life of IV insulin is like about 5 minutes. So like after like 4 or 5 half-lives, something is out of your body, right? So you turn off the insulin drip, like 30 minutes later, there's no more insulin in this type 1 diabetic who's going to go right back into DKA. Furthermore, if you choose to start an insulin like insulin glargine, that insulin takes 2 to 4 hours to kick in. So it's really always important to, before you shut off the insulin drip, you want to actually give insulin like insulin glargine and wait 2 to 4 hours before you shut off the insulin drip to make sure that there's always going to be insulin in this type 1 diabetic, that you're not going to put them back into DKA. The other endocrine emergency that we see mostly in type 2 diabetics is the hyperosmolar non-ketotic syndrome, or the HHS, and the hyperosmolar hyperglycemic state. The name of this has changed so many times in my training. And this is usually, again, a type 2 diabetic, usually an elderly patient, and the pathogenesis is poorly understood, but it's really a dehydration type syndrome. And they don't get into DKA because you need just a little bit of insulin around to prevent ketosis. So there's no ketosis, but they end up getting this vicious cycle of hyperglycemia leading to an osmotic diuresis and then volume contraction. And then they develop a prerenal azotemia. They're dehydrated. They have a further hyperglycemia, further diuresis. Often this is occurring in the elderly who have poor thirst mechanisms in place, or they just like have trouble getting up and getting out of bed and getting themselves fluids when this is developing. And believe it or not, this condition actually has a higher mortality than DKA, the hyperosmolar non-ketotic state. And it's because who gets it, right? It's usually elderly patients. And something also might have set them off, a UTI, pneumonia, heart attack, something like that. Okay, so those are the bad diabetes complications. But in the outpatient setting, we want to monitor at every visit for blood pressure. We want to do a foot inspection. Every 3 to 6 months, you're supposed to check an A1C level. And annually, we check for microalbuminuria. Annually, patients should have a dilated ophthalmologic exam. If they should have a foot exam every year. If the foot exam shows an abnormality or they have decreased sensation to monofilament, that's when they need to have further care with podiatry, that they're at high risk for having diabetic foot issues. And annually, we check lipids. So the neuropathy that occurs, it can happen in any part of the peripheral or autonomic nervous system. And the peripheral symptoms are kind of like what like the numbness, tingling, pain, and it's in like a stocking and glove distribution. And as I was saying, like the loss of sensation could put the person at high risk for a diabetic foot. But also we can't forget the autonomic symptoms that happen with poorly controlled diabetes, starting with just like a resting tachycardia, and there's a loss of beat-to-beat variability on the EKG. As bad as orthostatic hypotension can occur if the neuropathy is really bad. Gastroparesis can occur with end stages of poorly controlled diabetes, erectile dysfunction, diarrhea, all part of the neuropathy. Oh, so somebody asked, when do you start an ophthalmologic exam in type 1 and type 2 diabetes? And it's like as if I planted you in the chat. This is like totally something we ask the endocrine fellows. So we know that it takes at least 5 years, if not more, of poorly controlled diabetes to develop these microvascular complications of retinopathy and nephropathy. Okay, so in a type 1 diabetic who's newly diagnosed, there is no point to ever check their eyes or their urine for microalbumin for at least 5 years, because even if they're the worst controlled, it's just not going to happen and it's a waste of resources. So that's type 1s, you wait at least 5 years. Type 2s, the problem is they might have had type 2 diabetes for years and years and years before you're ever seeing them and diagnosing them. So in type 2 diabetics, we say at the initial diagnosis is when we start screening for the microvascular disease. I hope that answers that question. I like that. That was a great question. Okay, so diabetic neuropathy treatment, I'm putting this on there because, again, this is something that's definitely changed in my years of training. In the recommendations for 2017, and it has continued in the ADA recommendations up to now, the 2021 ones recommend either pregabalin, duloxetine, or gabapentin. All three of those have good clinical evidence as being recommended for initial pharmacologic treatment for neuropathic pain in diabetics. Unfortunately, we haven't come up with anything better since 2017, and it's still a debilitating disease, but these three drugs are all considered appropriate first-line agents for the ADA for diabetic nephropathy. Diabetic neuropathy. Okay, so the dreaded diabetic foot, it's kind of like a combination of all these things going on. So there's the sensory loss and the loss of proprioception. So they have this abnormal gait, and they just, the patients are kind of like rubbing the foot in weird areas that aren't supposed to be put pressure on when they're walking, and there ends up becoming this repeated trauma to the tarsal bones and the soft tissue. And as you know, a lot of these patients also have peripheral arterial insufficiency and obesity, so they're not going to heal ulcers as well. And the ulcers can cause osteomyelitis, which can cause gangrene, and then, the dreaded diabetic amputation that we all think about as these end-stage complications of uncontrolled diabetes. And like I was saying, screening with a monofilament has been studied and is a good marker, and yearly foot exam is important. And then you educate the patient about foot care. I have patients who literally can't feel anything on the bottom of their feet, and can't tell you how many times they either walk on hot pavement and get 3rd-degree burns. I had a patient once walk around with a needle in the bottom of his foot. They go to the beach. They have shells stuck in the bottom of the feet. They don't look, these patients who have no sensation have to every day, every night before they go to bed, really look at the bottom of their feet, use a mirror or something like that, put on the floor, make sure that they don't get these dreaded complications, because they just, as you probably know, don't heal well either. And it could go right from a small wound to, osteo. Retinopathy, right? You should be able to recognize this. I'm terrible at doing my ophthalmologic exam. Hopefully you guys are better than me, but you should be able to recognize these complications of diabetes, like the hard exudates, which are those discrete white and yellow lipid deposits. And that could be seen in anything that causes chronic vascular leakage, like diabetic or hypertensive retinopathy. And then macular edema, we see here, you see these dot and blot hemorrhages that occur also with diabetes. And about 35% of diabetics will develop end-stage renal disease and develop retinopathy. And oh my goodness, my slide is titled wrong. This slide is supposed to be titled, I'm sorry, things got changed around in the formatting. This slide, oh my God, I'm gonna really do this. Diabetic nephropathy. Yeah, I can do that while I'm typing. So diabetic nephropathy, the next thing I want to talk about, 35% of diabetics develop end-stage renal disease. It is the most common cause of dialysis here in the US. And as you know, the first sign is having this microalbuminuria. We check the albumin to creatinine ratio. You should screen that yearly. We treat an elevated albumin to creatinine ratio with an ACE or an ARB, or even the studies have shown just blood pressure control with any agent is actually even okay. Just really the most important thing is starting to keep the blood pressure down. But if you were going to pick any one agent, an ACE or an ARB is first line, and you want to optimize the glucose control. So another complication of diabetes that we don't see that much, but I want you to know about is this necrobiosis lipoidica diabeticorum. And sometimes this can even happen before the onset of diabetes. And it's kind of this is a nasty version of it, but it's a chronic granulomatous rash on the lower legs. And it looks like there's these shiny red-brown patches, and you might see this kind of yellowish open sores in the middle. And it has this look, and it's a specific thing related to high sugar and diabetes, again, necrobiosis lipoidica diabeticorum. And you should be able to recognize that. Okay, so how do we prevent these microvascular complications? We know very well now, we have really good data from the diabetes complications trial. This was a US trial, and the volunteers were randomly assigned to one of two groups. So the conventional group got 1 or 2 daily insulin injections a day, and the intensive group got multiple daily insulin injections a day, like basal bolus therapy, and a few of them actually wore external pumps, and they were studied for an average of 6.5 years. And what you can see is there is like a direct correlation between the higher the A1C, the more retinopathy, nephropathy, neuropathy, and microalbuminuria. And the better controlled the A1C, the less of these complications. In the chat. Once diagnosed with microalbumin and treated with an ACE or ARB, is there a rationale in continuing yearly microalbumin checks? I think yes, because what you would do is, if the microalbuminuria is going up or it's not improving, you actually bump up the dose of the ACE or the ARB. You want to maximize those agents. It's not just like you put one on and let your microalbumin be like 200 creatinine ratio. You want to actually get it as low as you can go while still not having hypotension. So we do continue to screen. Okay, so I just showed you we can totally prevent microvascular complications by controlling the blood sugar. But, oh no, my slides aren't. Okay, how do you prevent a cardiac event? So let's say you have a 65-year-old male and he comes to you because he's about to become a grandparent and he's really worried about dying of a heart attack like his father and brother did before they ever got to meet their grandchildren. He's obese and his BMI is 32.3. He doesn't exercise regularly. He's had type 2 diabetes for 12 years. He's on insulin glargine, 30 units at night, glimepiride 4 milligrams a day, metformin 1,000 milligrams BID, and sitagliptin 100 milligrams a day. He has mild neuropathy, no retinopathy, and his urine microalbumin creatinine ratio is 30. His A1C is 8%, and fasting blood sugars are 120 to 160. He takes enalapril 20 a day, and his blood pressure is 154/84. He takes simvastatin 40, and his lipid panel shows total cholesterol 210, triglyceride 205, LDL 90, HDL 40, and he also takes a baby aspirin a day. Okay, sorry, that's like a complicated question. I could always go back if you need me to, but my question is, if you could make one change at that visit to prevent cardiovascular disease, which is what he cares about right now, what would it be? Would you A, stop his oral diabetic medications and switch him to basal bolus insulin and titrate that to an A1C goal of less than 7%? Would you B, increase his simvastatin to 80 milligrams? Would you C, increase his enalapril to 40 milligrams a day? Or D, would you add fenofibrate? What are you thinking? Okay, we're a little bit all over the board, but most of you got this right. The right answer is C. The best way to protect him from having a heart attack is to optimize his blood pressure medication. That's the right answer. So we know that cardiovascular disease is the major cause of morbidity and mortality for those with diabetes. And that hypertension, dyslipidemia, those are clear risk factors. And like, you know, we call diabetes like a cardiac equivalent. Just having diabetes makes you at risk for having cardiac disease, as if you've already had an MI. And there's really strong evidence for managing each of those cardiovascular risk factors for primary and secondary prevention. And it's a little controversial, but most people say that the blood pressure goal should be less than 140/90 in diabetics. And most say that patients with diabetes should be on a moderate to high intensity statin to control those risk factors. And in the case I gave you, the person's blood pressure was definitely elevated. They were not optimized. And controlling their blood sugar, for better or for worse, unfortunately, we now know is not going to prevent them from having a heart attack. All the big trials that looked at this, ACCORD, VADT, the ADVANCE, all of these trials, lower blood sugar does not lead to decreased heart attacks. In fact, those patients that they really tried to push, as you know, in those trials had more cardiovascular disease and events. The only way to really prevent a cardiovascular event in somebody with type 2 diabetes is to manage the risk factors, blood pressure, cholesterol. Those are the main ones. So again, like I was mentioning, that when we try to use intensive insulin or oral hypoglycemic agents to push the A1C to less than 6.5, I can reduce, again, retinopathy, nephropathy, neuropathy, but it will lead to hypoglycemia often. And these hypoglycemia episodes set off kind of these counter-regulatory responses, cortisol, epinephrine, norepinephrine, growth hormone, glucagon, and all of those things actually can put a patient at high risk for arrhythmia and sudden cardiac death. It prolongs the QT interval. And as I'm saying, we know that there's increased cardiac death rates in patients who have recurrent hypoglycemia events. And this is what kind of precludes us from doing tight control in every patient. So over the last couple of years, and this is directly from ADA, it changed in 2018. And again, I'm showing you 2018 slides, but I promise I looked at the 2021 standards of care for diabetes, and it's no different. And they talk about that you have to look at each patient in order to decide what's your therapeutic target for diabetes. And if the person has a long-standing diabetes with multiple other things going on and a not long life expectancy, then maybe you want their A1C to be higher than 7 to avoid hypoglycemia. However, if this is like a young patient who's highly motivated and has excellent self-care capacities, you should try to get their A1C less than 7% to prevent these microvascular diseases. So you basically should go as low as you could possibly go safely while avoiding hypoglycemia. And the ACP came out the same year with a controversial statement in 2018. And basically the statement said that clinicians should aim to achieve an A1C level between 7 and 8% in most patients with type 2 diabetes. And again, it was the same sort of reasoning that made them state this. And the thing I agree with that. Like, so in most patients, if you can't get them low, maybe you can let them be 7 to 8. The part that was more controversial is they said that clinicians should consider de-intensifying the pharmacologic therapy in patients with type 2 diabetes who have an A1C less than 6.5. So again, if you can control people and their A1C is 6.4 and they're doing completely fine and they have no hypoglycemia, you don't necessarily need to cut back on their medications to let them be between 7 and 8%, especially if they were doing well and they were well controlled. So again, it's always hard to make these one size fits all rules. ACP tries to make position statements based on evidence. But again, it's something to keep in mind that the therapeutic targets for diabetes really need to be tailored to the patients and their risk profile. So like I was talking about earlier, like with my son, it's really important to recognize the early signs of insulin resistance and type 2 diabetes so that you could possibly prevent the progression of the disease. And what this slide is meant to show you is actually that by the time, so see, when your impaired glucose tolerance and your insulin sensitivity is going down and your insulin secretion is going really, really high, you still have normal glycemia. By the time you actually get diagnosed with type 2 diabetes, that your sugar goes high enough to be diagnosed with type 2, at that point, you've lost about 50% of your beta cells. And it's all like, this is late type 2 diabetes where you're on insulin and you have all those complications. That's like considered beta cell exhaustion. We have used up our beta cells. The person needs to be on 4 shots a day of insulin. But again, by the time you're diagnosed, we say that about half your beta cells are not working well. So what if we could diagnose this much earlier on or make interventions much earlier on to preserve that beta cell function? And so one of the largest trials that looked at this, and I love this trial, I like literally sometimes print it out and hand it to patients, was the diabetes prevention program. And what this was is they took 27 randomized centers and they looked at whether lifestyle intervention versus pharmacologic therapy, metformin, could prevent or delay the onset of diabetes in individuals who were high risk. So they had to have impaired glucose tolerance or family history, or like gestational diabetes and obesity, people who had like basically pre-diabetes. If we gave them lifestyle versus metformin versus nothing, how many of them went on to develop full-blown diabetes? And what happened was the lifestyle intervention and metformin group were both effective in decreasing the incidence of diabetes, as you can see here, compared to the green line, the placebo. But the cool thing is that lifestyle is even better than metformin. And what was the lifestyle in this study? Here's the problem. So the lifestyle was 120 minutes a week of exercise. And studies have come out after that looking at like 100 minutes a week, 90 minutes a week. Now, it seems like you have to have at least 120 minutes a week of exercise. And the patients lost about 7% of their body weight in this trial. And like when we say lifestyle, they literally had these life coaches calling them every day and being like, did you eat today? Did you exercise today? What did you eat? Are you doing the right thing? But if you have the time for it, or the patient has the motivation for it, lifestyle is better than metformin in preventing diabetes. That's kind of like the take home point of this. Okay. Any questions so far? And I'm going to move on to kind of pharmacotherapy. Okay, so let's say you didn't prevent it and the patient ended up developing type 2 diabetes. Diet and exercise are always going to be your first line agent. I'm seeing that there's a question. What proportion of patients with prediabetes go on to have type diabetes? Should we treat patients with prediabetes the same as patients with diabetes in terms of lipid management? What about the ASCV 10-year risk score? Do we check the DM box? So pre-diabetics do not check the DM box in the ASCVD 10-year risk score. It's really type 2 diabetes that's been studied as kind of like that cardiac equivalent. And same thing with lipid management. And again, you can talk to a cardiologist maybe more about this, but pre-diabetics are not kind of put in the same boat as everyone needs at least a moderate intensity statin as patients with type 2 diabetes. But to answer the question of what proportion of patients with prediabetes go on to develop diabetes, you can see back in this trial. So over like 4 to 5 years, the cumulative incidence is, you can see here that it's like, I think the way the trial was read, that it was like at 4 years after doing nothing, about like 30 to 40% of patients will go on to develop full-blown type 2 diabetes. So it's not everybody. It's still less than 50%, but this is over a short 4-year period. So like kind of if you take it on and on and on, these patients are very, very likely, almost certain to go on and develop type 2 diabetes over time. If that helps. So someone's asking if we treat with lifestyle and they fail, should you use metformin? And again, this is where I present this to my patient. I actually show them this. So like metformin, it's not perfect and lifestyle is better. And if you could do the lifestyle, it's better. And, you know, if the person is very concerned about developing type 2 diabetes and wants to go on a pharmacotherapy, metformin will reduce the risk of developing diabetes about relative risk reduction, about 31%. But I'm not saying that you should put every single person on metformin. Again, that's like a controversial thing. And the risk benefit ratio is not necessarily at the point where we say everyone with prediabetes should be on metformin. No, we're not saying that. It's an individualized decision. And there's definitely side effects of metformin, which I'm going to get into right here, but metformin can cause GI upset. It can cause a B12 deficiency, metallic taste. There's, you know, people are looking in the labs, metformin may actually even decrease exercise tolerance. So metformin plus lifestyle is not necessarily as good as lifestyle if you're really doing it. And it might actually decrease the oxygen capacity and things like that of exercise if you're on metformin. So it's definitely controversial. Definitely not everybody needs metformin if they're pre-diabetic, but you can go over this with the patient and talk about the risk versus benefits and the relative risk reduction of metformin. It's about 31%. So again, metformin, if you have type 2 diabetes, it's still the first line oral agent. Always, this is what you should be using. It's contraindicated if you have impaired renal function or if the person's about to get radiocontrast material, because the metformin, the way it works is it decreases gluconeogenesis. And if somebody has lactic acidosis for whatever reason, the only 2 ways your body can get rid of lactic acid is by peeing it out or by incorporating it as like a 2-carbon moiety to make sugar in gluconeogenesis. So if you block gluconeogenesis and your kidneys fail, you have no way to get rid of the lactic acid. That's why we don't use metformin in those situations. But metformin does not cause renal disease. And metformin actually more and more we're saying is safer in kidney disease. The current guidelines are saying that as long as the GFR is greater than 30, you can consider reduced dose metformin. That it used to be off limits for everyone who had kidney disease. And again, we're finding more and more that it's safe. You don't want to use it if the person is severely ill or, you know, has a hypoxemic condition, but otherwise it's safe. Other drugs. So the most commonly used drug in some of the European countries is the alpha glucosidase inhibitors as the first line agent, like acarbose. And what this does is it blocks complex carbohydrate absorption at the brush border of the intestine. And it just basically blocks you from absorbing sugar from your diet and lowers blood sugar that way. but it causes a lot of flatulence and bloating and diarrhea. And our patients here in the US, they're not willing to put up with those kind of side effects. So we don't use it that much, but it definitely works, and it's a good kind of early elevated blood sugar agent. Other drugs, the sulfonylureas and the meglitinides, like glimepiride, glyburide, glipizide, repaglinide, nitaglynide, they cause insulin secretion from the beta cell. So you take the pill, and some of them are longer acting or shorter acting, and they work on the calcium channels of the beta cells, and they make your body squirt out insulin as soon as you take the pill. And it's good because it's strong, and you squirt out insulin and it lowers the blood sugar. However, the side effects are weight gain and hypoglycemia, right? If you squirt out insulin and you're not eating food for that insulin to necessarily work on, you can end up with hypoglycemia, and we worry in renal disease. And these drugs, they're cheap and they're easy to get, but they're more and more frowned upon just because of the weight gain and hypoglycemia side effects. And they're not necessarily have cardiovascular benefit. And we have so many diabetes drugs nowadays that have cardiovascular benefit. So again, if you have somebody who has, the best insurance in the whole world, and you can give them any drug in the whole world, you're not going to use a sulfonylurea. But in real life, you can get this for $4 at Walmart, and it's a strong diabetes pill, and we use it more often. Another cheap drug that we can get, because it's generic, is the thiazolidinediones. And this is the only drug that is a true insulin sensitizer, that it literally acts on transcription and improves peripheral insulin sensitivity. And because it's literally working on transcription factors, it takes like 10 to 12 weeks to see the full effect. So you're not going to start this drug and have better sugars right away. And if you stop it, it takes a while, to stop seeing the effect. And the issue with this drug is it causes weight gain and fluid retention. It can worsen osteoporosis. And we ran into a lot of trouble when it first came out because people were using it in patients who had CHF or who had issues with fluid retention. And as I said, it causes fluid retention, so it can exacerbate CHF. In patients using insulin and thiazolidinedione, often there's a lot of fluid retention. Both insulin causes fluid retention as well and weight gain, and this drug causes fluid retention and weight gain. So we say, to really watch out in patients who you're worried about their fluid status and gaining weight. Other pharmacotherapies for type 2 diabetes, the DPP-4 inhibitors, I'm listing them there. And they block that DPP-4 enzyme, which is responsible for cleavage and inactivation of GLP-1 and GIP. And there's rare side effects. They're easy to use because there's really just not that many side effects. They're safe in renal disease. Some of them require renal dose adjustments, but they're generally safe and well tolerated in renal disease. They don't cause weight gain. They don't cause weight loss. There is a risk of pancreatitis. There is, with one of them, there might be increased heart failure hospitalizations, but they're, not very strong diabetes drugs, but generally well tolerated. I tend to use these drugs a lot in elderly patients who I want to just add on one other thing, and I don't want to cause that many side effects. I'm looking in the chat to see the questions. Okay. Other things to think about, these two classes of medications, the bile acid sequestrants and the dopamine receptor agonists, are both FDA approved for type 2 diabetes treatment. You may have never used them or heard of them for these things, but you should know because they are FDA approved for this. So clocevilam is approved for this. It lowers LDL, so we use it for cholesterol. And the mechanism is unclear, but it has something to do with the glucagon-like peptide 1 system in the intestine. And it can cause GI upset, increased triglycerides, and there's only like a minimal effect on blood sugar, but it can lower blood sugar. Similarly, the dopamine receptor agonists, which are quick-release bromocriptine, this does something up in the brain. And like I was telling you, like the brain is a diabetes organ, and it modulates hypothalamic regulation of metabolism by like lowering, by affecting the dopamine levels, by raising dopamine. And you have to take it first thing in the morning when you wake up. It's like interesting. If you take it later in the day, it doesn't have any effect on sugar. But if you do take this early in the morning and you modulate your dopamine, the people have more insulin sensitivity as the day goes on while they're eating if they took this pill in the morning. And again, it's not a strong effect. It's a pretty mild effect, but you should know that these are things that are on the markets, especially if your patients ask you about it. Somebody's asking oral DPP4s are oral. Yes, DPP4s are oral. They're all oral. I don't know if I said something that it wasn't. Now GLP-1 agonists. So this is the DPP4s stop the breakdown of glucagon-like peptide 1. Glucagon-like peptide 1 has a very, very, very short half-life. And they've created forms of it that last in your body a lot longer. And I'm naming them here, and some of them are very short acting and need to be injected like twice a day. And then they've invented newer forms of them that are injected once a week. And we even have oral semaglutide, which is a GLP-1 agonist put in a pill form. That's the oral form. So at this point, we have daily and weekly GLP-1 agonists, as well as a daily oral form of it. And the way these work is they stimulate insulin in response to elevated slow gastric emptying, so the patient feels full, and the full could be good or bad. Lots of GI upset, sometimes nausea, vomiting. It depends on how much they eat, what they're eating, and how sensitive they are to this gastric emptying. And it works on the hypothalamus and tells your hypothalamus that you're full. So it has all of those effects, which cause weight loss and coronary vascular disease reduction. The DPP4s and the GLP-1s all have a possible pancreatitis risk. We say not to use this in a patient with history of pancreatitis or high risk for pancreatitis. And then the only other thing about the GLP-1s is they cause C-cell hyperplasia in rats. And the C-cells are those cells that make parathyroid hormone around the thyroid gland and are turned into cancer in medullary thyroid cancer. So if someone has a history of medullary thyroid cancer or a family history of like MEN syndromes, we say not to use these drugs. But these drugs are completely safe in people with the run-of-the-mill papillary differentiated thyroid cancer, only the medullary thyroid cancer MEN syndromes. Okay, so the last class of drugs I want to talk about, and again, I can like talk all day about diabetes drugs. I want to cover other things, but the SGLT2 inhibitors, which like every day I get something in my inbox about a new indication for an SGLT2 inhibitor, and I guess you guys do too. There's 4 of them on the market right now, and they block reabsorption of glucose from the proximal tubule in the kidney. So you're basically peeing out about 200 grams of sugar every day when you take it. And the benefits are cardiovascular disease, heart failure reduction. Some of them have indications for heart failure hospitalization. Now, some of them have indications for decreased kidney disease progression in patients with and even without type 2 diabetes. They can lead to a mild weight loss. As diabetes drugs, they're not great diabetes drugs. And then the other thing I want to put out there is there's a decreased efficacy of having you pee out sugar the lower your GFR is. So if you're using this in someone with chronic kidney disease or heart failure risk, that's great, but the lower the GFR, you're not going to actually see an improvement in blood sugar. So you kind of got to think of it that way. And then the side effects are UTIs and genital candida infections. We've seen nasty Fournier's gangrene occur in this. And basically, bacteria and genital infections, they love sugar. And that's what diabetics are at increased risk for having these kind of genital infections. And now if you're going to have tons of sugar in your urine, it's going to put you at even higher risk. Other things, because it's kind of like a diuretic, you can have volume depletion. We see a normoglycemic DKA that happens rarely, but in patients who are DKA prone or undiagnosed type 1 diabetics, they can actually go into DKA on these drugs. So it is advised that these medications are discontinued with any illness or prior to surgery to avoid this risk of DKA. The amputation risk was on one of the labels, but it seems like it's not so actually a thing to worry about. But we know that there is, it's a diuretic. So if somebody has peripheral vascular disease and they're on too much diuretic, you can decrease blood flow into the extremities. And it does increase LDL cholesterol as well. So this is a really, really busy slide. And you guys will kind of be able to have access to these slide sets and everything. But this is the 2021 American Diabetes Association. How do you choose what drugs to use for type 2 diabetes? And again, it's crazy and it's expanded so much. And what I want to really show you is So first, that metformin and lifestyle is always the first thing. But see this whole section over here, this is all brand new on these guidelines that was not on the previous ADA guidelines. And basically what they're saying is that if a patient has an indicator or high risk for ASCVD, CKD, or heart failure, you might go down this pathway as your first line thing to pick drugs that have been have evidence in populations like GLP-1s, SGLT2s, which can reduce these comorbidities rather than affecting A1C or glucose control. And remember I said a lot of times, especially if the patient has like renal disease, it's not even gonna like lower the blood glucose. So this is individualized. So this is considered independently of their A1C or their A1C target is this section on drugs to use. Now, if you care about lowering their sugar, then you're gonna think about all these other drugs like insulin and sulfonylureas and go down kind of this other pathway. But again, this is very new for 2021, is this whole new pathway added to the algorithm. And I'm sure this will continue to evolve. We're all kind of right in the middle of seeing this happen. Again, this is a very busy slide, but this slide points out when considering that therapy needs to be intensified in order to reach your A1C goal, the newer things that they're saying is, so it used to be like you're not well controlled on 3 oral meds or your A1C is above 10. It used to be like, okay, now you add insulin. That was like the guideline for a very, very long time. But what we're finding is that the GLP-1s, mostly the injectable ones, which are more efficacious and stronger, the GLP-1s can be as strong as insulin. In fact, there's been studies of head-to-head of GLP-1 versus mealtime insulin, and it has the same efficacy. So the new thing is to add some sort of injectable, but you may want to add a GLP-1 before you add insulin if you're at that point where the person is failing, like let's say 3 orals or their A1C is high or something like that. And then, you know, the next step again is going to be insulin, adding on basal insulin. And if they're still not controlled, then you add on bolus insulin. So this is kind of where we are in the algorithms, but there's so many drugs and everything has to be individualized to the person and what kind of insurance they have. And if there's a risk of hypoglycemia, and if you're really trying to prevent weight gain, then you don't want to use agents that cause weight gain. You got to think about all these things. So insulin itself, you know, is essential for treatment of type 1 diabetes. And about more than half of patients with type 2 diabetes eventually end up on exogenous insulin. And like I said, we have to worry about hypoglycemia and weight gain. So sorry, I've been talking a lot about these drugs. Let's get back into asking you guys what you think some of these questions. So let's say we have a 32-year-old woman who has type 1 diabetes for 16 years, and she reports 3 weeks of fatigue, excessive sweating, and occasional headache on awakening. She's using 32 units of premixed insulin twice a day. And she exercises each evening after work and occasionally experiences hypoglycemic symptoms around lunchtime if she doesn't eat. She monitors her blood sugar twice a day, and her blood glucose log shows fasting sugars 125 to 146, pre-dinner sugars 176, and her A1C is 7%. She's engaged and she's going to be planning a pregnancy in the next year, and she really wants to get her A1C lower as part of preconception. Exam reveals normal weight and blood pressure, and she has no evidence of diabetic complications. So I'm going to ask you a couple of questions about this patient. So I just want to review. She's on pre-mixed insulin 7525 NPH Lispro mix twice a day. And she's having these things where she has 3 weeks of fatigue, excessive sweating, and headache on awakening. So my first question for you is, which of the following is the most likely cause of her symptoms? Do you think it's A, nocturnal hypoglycemia, B, the dawn phenomenon, C, sleep apnea, or D, pheochromocytoma? What do you think? Okay, good. And most of you got this right, that this is nocturnal hypoglycemia. And you might be familiar with the terminology, the Somogyi phenomenon, also known as post-hypoglycemia, hyperglycemia, or chronic Somogyi rebound. Those terms have kind of fallen out of favor. We're not sure if that really exists, but we do know that people definitely have nocturnal hypoglycemia and end up having all these symptoms in the morning, a lot of headache on awakening, fatigue, sweating, those sort of things. And the dawn effect, which is kind of the opposite, what's not happening here is what happens with that is that they have an elevated morning blood sugar in response to the waning levels of insulin and a surge of the counter-regulatory hormones that happen overnight. So nocturnal hypoglycemia can cause high morning sugars and not feeling well, but so can the dawn phenomenon where the sugar just creeps up and creeps up and creeps up and peaks kind of early in the morning because of the counter-regulatory hormones, which can happen. Okay, so my next question about the same lady is, so which of the following options is the most appropriate management to improve her control? Do you want to A, increase the dose of her morning premixed insulin and decrease the dose of her evening insulin? Do you want to B, increase the dose of both the morning and the evening premixed insulin? Do you want to C, switch to self-mixed NPH and Lispro before breakfast and supper? Or D, do you want to change the insulin to glargine at bedtime with 3 pre-meal injections of Lispro a day? Or E, should she just reduce her caloric consumption to improve her sugar prior to getting pregnant? What do you think? Okay, and most of you got this right. And so this has been well studied that in patients with type 1 diabetes and suboptimal glucose control, using a more complex regimen with more frequent injections usually provides more effective control. And what we're trying to do is mimic the normal secretory pattern of insulin. So each time, so everybody has like a basal amount of insulin all the time, sleeping, eating, whatever. So we want to give a basal insulin. And then every single time you eat a meal or eat a snack or anything with more than 15 grams of carb in it, your body is going to squirt out insulin to cover that. In fact, like even just because I said 15 grams of carb, even there's a salivary response that happens. So just even like sipping water or putting something in your mouth, your body makes a teeny bit of insulin. It primes itself to make a little bit of insulin just when you start to salivate and the food even goes in your mouth. There's a cephalic, like oral phase of insulin response. But the big amount of insulin is squirted out each time you eat a meal. And that's what we want to mimic with our pharmacotherapy to get the best diabetes control. So, you know, what you would do is give the person a basal long-acting insulin, such as one of these. And then you would say, okay, every time you eat, no matter what that is, you're going to use some sort of rapid insulin that is designed to cover the carbohydrate load and the sugar excursion that happens with that carbohydrate load. So let's say you had a type 2 diabetic patient who's admitted to the trauma service, ICU, after a motor vehicle accident. And on his home meds, he's taking insulin glargine, 50 units twice a day, and Humalog, 40 units with meals. He weighs 80 kilograms. He's intubated and sedated and requiring pressors. He's going to require surgery in the morning. You're writing his admission orders. His blood sugar is 362. What do you think you should write for his admission orders? Do you want to order him A, insulin glargine, 50 units twice a day, his home dose? B, Humalog sliding scale insulin every 6 hours, where you say if his sugar is 0 to 150, don't do anything. If it's 150 to 200, 1 unit. Do you want to put him on an IV insulin drip? Or do you want to D, order insulin glargine 20 units a day, which is his weight-based dose of insulin? What do you think? Okay, and most of you got this right. So again, the key thing in this question is that the patient is critically ill in the ICU. And so it doesn't have to be as difficult. I'm going to tell you to put the person on an insulin drip at that time, that you don't have to do all the math and calculate it out. So let's use this as a segue to talk about diabetes care in the hospital. So these are the ADA guidelines that basically say insulin therapy should be initiated for treatment of persistent hyperglycemia, and you start it at a threshold of 180. So anyone in the hospital who has sugars over 180, you should be using diabetes treatments, and insulin is the therapy of choice for somebody who's in the hospital. And then you would ideally use a basal bolus regimen where you would use maybe some nutritional insulin in patients who have good nutritional intake. Is the way that you would do that. And using sliding scale alone in the hospital setting, it's like the pet peeve of the endocrinologist. Like every endocrinologist is like, we hate sliding scales. And hating sliding scales is like, there's a place for a sliding scale. It's a correction scale. It could be used to like correct hyperglycemia on top of like a basal bolus regimen where you're already giving the person insulin and then you use a little bit more, but just using a sliding scale for someone who comes in the hospital, that's reactionary. It's very discouraged. It's been studied in clinical trials. It is not as good as using weight-based regimens and basal bolus. And you're going to adjust the insulin for a target sugar of 140 to 180. And again, this is new. This 140 to 180, that's all based on the NICE sugar trial that came out. If you guys should know it, one of the landmark trials, they looked at like about over 6,000 patients who were critically ill. And we liked the trial because a lot of the patients were in medical ICUs versus in other trials, they were all surgical patients. And basically they either tried to get their sugar to like conventional range, less than 180, or to get the sugar less than 100. And the 90-day mortality in the groups that they tried to get the sugar less than 100 all the time, those patients had a higher 90-day mortality. So we're like, okay, if you try to really aggressively care for our patients, like especially in like the ICU setting, they ended up dying more. So we say blood glucose targets for insulin are 140 to 180. If they're critically ill, you want to use an insulin infusion. IV insulin is the easiest way to do it. You might see more stringent goals, in people who have had a cabbage, or in other cases where they might aim for 110 to 140. But again, based on the NICE sugar trial, 140 to 180 is kind of the sweet spot. And if they're in the ICU, using IV insulin is the easiest way to do it. In the ICU, I can't even tell you how much. So you design an insulin regimen, the person's on tube feeds, let's say, continuous tube feeds. Every time I walk into the ICU, my patient who's supposed to be on continuous tube feeds never has the continuous tube feeds running. Either there were residuals, or the person pulled out the NG tube, or they're going for a study, or they're washing the patient and they have it on hold. So again, using IV insulin is easiest that you can turn it off, turn it on, go up, go down as the clinical status changes. First, if you're giving a long-acting insulin as the only kind of insulin for somebody who's on, let's say, like continuous tube feeds, once that insulin is given, you can't take it back if the tube feeds stop. Okay, so that's my hospital stuff. I wanted to move on and talk a little bit about gestational diabetes. We're seeing more and more of it, and it's just, in definition, it's diabetes diagnosed during pregnancy. Now, there's people who have type 1 diabetes already know and get pregnant, but in this case, we're talking about people who were diagnosed when they were pregnant, and they very may well have undiagnosed type 2 diabetes, or just have this pregnancy-induced insulin resistance that happens. But in the gestational diabetes that occurs, most of it goes away, the insulin resistance goes away as soon as the baby is delivered. We care about it because there's so many complications. Hyperglycemia first trimester causes fetal malformations, mostly the endocardial cushion tissue, they can have defects. So that's why in that other vignette, anyone who has diabetes and they're planning a pregnancy, we're like, you got to get your A1C less than 6.5 before you get pregnant, because first trimester is when you can end up having these fetal malformations. But later in the pregnancy, they can have preeclampsia and macrosomia of the baby from the sugar levels being so high. The baby is making tons of its own insulin because the baby's like, oh my God, there's so much sugar around. The baby makes more insulin, and insulin is a growth factor. So the insulin causes the baby to have macrosomia. And also the baby is using up the insulin in its pancreas while it's sitting in the mom. So that actually increases the risk of type 2 diabetes down the road in the mother and the infant, because the infant, starts to has a higher risk of developing insulin resistance and diabetes down the way. And God forbid, fetal death can happen. So gestational diabetes, we screen high-risk women in the first trimester. And high-risk women are very obese patients, or patients who had pre-diabetes before getting pregnant, or people who had a history of gestational diabetes with a different pregnancy. But everybody else who you're going to screen, you screen them later in pregnancy when the insulin resistance of pregnancy really hits, later at like 24 to 28 weeks. And the preferred treatment is, first you start with dietary changes, like a nutritionist is this person's best friend. But if they're failing dietary modifications, insulin is the preferred treatment. And the guidelines that we use to say, like, what should your fasting blood glucose be when you're pregnant? It's less than 90. We use really, really, really stringent guidelines to protect this baby, very different than just normal type 2 diabetes. So often we have to be very aggressive with the medicines in order to get the sugars less than 90 fasting all the time. And again, the part that, you're like, oh, I'm not going to manage this anyway. This is for the OBs, fine. But the part that you have to know is if somebody has gestational diabetes, they're at very high risk for type 2 diabetes down the line and maybe even persistent diabetes. So you're supposed to do a 2-hour oral glucose tolerance test 6 weeks postpartum in order to diagnose if they still have diabetes after they've delivered the baby. The glucose tolerance test, because it's 6 weeks, right? And A1C is a 3-month average, and it's not going to tell me about what's going on. A1C is very inaccurate. It's always falsely low in a pregnant woman. So I can't really use A1C at that time. So the textbook says glucose tolerance test at 6 weeks. If the person is more than like 3 months postpartum, yeah, you can use an A1C at that point. But early postpartum, an A1C is still going to be inaccurate. And we counsel these patients. So these are your patients who might be planning pregnancy. You need to really counsel them on the risk and development and progression of diabetes during that pregnancy. You want to get their diabetic control. The other thing to note is diabetic retinopathy often worsens during pregnancy. So these patients should have frequent eye exams before planned pregnancy. And we say monitored every trimester for even up to a year postpartum, because they have a risk factor of worsening retinopathy. Other interesting things or things to think about in your patients who might become pregnant, it's all these medicines that we give that I just said every diabetic should be on, like a statin, an ACE or an ARB, and we put a lot on aspirin. And a lot of these medications need to be avoided during pregnancy, might not be safe. So you really have to, somebody who's on a statin or an ACE or an ARB, those are teratogenic. You need to make sure that they're using some sort of contraception or that they know that they can't get pregnant on those medicines. The other caveat I want to point out, and this is something that's new that changed again during my training, is that women with type 1 or type 2 diabetes should be prescribed low dose aspirin, it's usually like 81 milligrams, from the end of the first trimester until the baby is born. It will reduce the risk of preeclampsia. So this is standard. This is guidelines since about 2019 when the evidence came out about this. And again, this is something that you might not be up to date on, and to know that all type 1 or type 2 diabetics need aspirin during pregnancy to prevent preeclampsia, end of the first trimester until the baby is born. So the other thing I want to talk about in our diabetics about preventing these complications is immunizations. We know that people with diabetes are at high risk of getting infections, and they're at high risk of serious problems, some from vaccine preventable diseases. And the ACP is really actively trying to push education on vaccinations. And I don't know if you guys have looked into this, but there has been a massive drop in routine vaccinations among older adults during this pandemic. I've seen the graphs, and literally the pandemic happened and nobody is getting their flu shots, Pneumovax, Zoster, everything is dropping and dropping off. And then of course now we have, and it's not even on here, COVID vaccine, but here's a condensed version of the recommended vaccines for adults with diabetes. And there are a number of them. And again, as a primary care provider or a diabetes provider, this is an integral part of your visit, is to make sure that your patient is up to date on their vaccinations. Okay, so this is not a real question, but you guys can maybe just write in the chat, which patient is at higher risk for type 2 diabetes and heart disease and having a heart attack? And maybe tell me why. The man over here or the woman over here? And people are writing things in the chat, and I definitely want to answer that. There's a pump question in the chat. So what we know is that adiposity is not the same in where you put it. And it's really central adiposity, like you see in this man, the central adiposity, that kind of beer belly shape, which really puts the person at higher risk for metabolic complications than adiposity in the hips and breasts and other areas. And it's not necessarily because this is a man or a woman. It's I definitely see women carry their fat centrally, and that's the metabolically active fat. And when you have central adiposity that I can see, you better bet that that person is going to have visceral adiposity. And it's that visceral adiposity, including the adiposity of the pancreas and the liver, which is filled with fat, that's going to lead to all of these metabolic complications, including type 2 diabetes. And this is a good segue that I'm going to come into my section on obesity, but just to, before I get into talking to you guys about obesity, there was a question on the pump. let me see. If a patient has a pump and is now hospitalized, oh, already a controversial thing. If the sugar is good controlled on the insulin pump, do you continue the pump? If the patient's sugar is not well controlled, do you start IV insulin? Okay, so each hospital should, and hopefully yours does, has their own policy on patients with insulin pumps. So I'm going to tell you that if a patient has an insulin pump and they know how to use it, and often now they have pumps and they have continuous glucose monitors, and if they're well controlled and they know how to use it, they are going to do so much better controlling their own pump and leaving it on them, rather than you trying to manage their insulin with subcutaneous insulin and the nurse checking the sugar like in the middle of the night or when they're almost eating and not even fasting, and ridiculousness that happens. However, if the patient is not well controlled or is not able to change their own pump settings and demonstrate, just like we go to the bedside and we're like, show me that you know how to use the pump and show me your settings and show me that you know what you're doing. So if they don't know how to like see what their settings are or know what their basal rates and boluses or how their pump works, those patients we say, we're taking you off the pump in the hospital. And then the other thing is if they're going to be unconscious and not able to use their pump or they're not going to be with it, you want to put the person on IV or subcutaneous insulin. So for like short procedures where they're going to be unconscious for like an hour or two, if they know how to use their pump, great, we let them keep it on. But like somebody undergoing like cabbage, you know, that person's not going to be with it for even like a day or so after the cabbage, we make them take their pump off. But each hospital should have a policy on continuous insulin infusion and pumps, and so that you could at least be like, this is our hospital policy. In a patient with type 2 diabetes from chronic pancreatitis who has good blood pressure and low LDL, should he be on a statin and ACE and ARB? So yes, so the statin is yes, regardless of LDL, there is cardiovascular benefit of statins in patients who have type 2 diabetes, even if they have a low LDL, no matter what. The ACE and the ARB, it doesn't look like there's benefit unless the patient has hypertension or microalbuminuria. So if there's a type 2 diabetes and they don't have elevated, microalbuminuria or blood pressure, they don't have to be on an ARB, regardless of if they have chronic pancreatitis or what the cause of their diabetes was. That's kind of my answer for that. Okay, so let's talk a little bit about obesity. So let's say you have a 54-year-old man with prediabetes and hyperlipidemia, like all these people we're talking about, and he's concerned about his risk of developing type 2 diabetes and cardiovascular disease. He understands that he needs to lose weight, and he has incorporated exercise into his routine by adding brisk walking for 25 minutes, 3 to 4 times a week, and he's begun weight training under the guidance of a trainer, but has not seen a significant change in his weight. Okay, so he's trying and he hasn't seen any weight change. And so the question is, which of the following diets is most likely to lead to long-term weight loss for this patient? Weight loss. A, low-fat diet, B, low-carb diet, C, vegetarian diet, D, Mediterranean diet, E, the DASH diet, the dietary approaches to stop hypertension diet. And I'm going to tell you how old I am because the DASH diet used to always be like asked on all of my exams. Okay, so don't hate me. Don't hate me. This is a trick question. And the answer is that there's no right answer. And it's really important for you to know this because, again, people ask us all the time that although there's discussion of what's the best diet, is it like low carb, low fat, protein, carbohydrate for weight loss, but all the real data on this show that no dietary intervention over another is better in the long term. So every study that's looking at somebody, do they lose weight and can they keep that weight off at 1 year? Because that's what you really care about. Like if you want to lose weight really, really quickly, yeah, you can just, do like a really, really extreme diet. But if you want to lose weight and keep it off at 1 year, it doesn't matter which one of these things you do. It really is whatever diet you can stick to and use and be comfortable with, that's the diet that you're going to have the most amount of weight loss on. So again, short-term differences in weight loss really have not been consistently reported. Like if you look at those trials, some say low fat, some say low carb. And again, it doesn't really show a difference. And if you look at long-term weight loss, every one of the diets is exactly the same. So we just say you find a diet that you can stick with long-term and you feel okay on and you can, do for long-term, and that's the best diet for losing weight. Now, which one of these diets may be most likely to reduce the risk of major cardiovascular events? What do you think for this one? Okay, most of you knew this. So yes, and the DASH diet has also been shown to have cardiovascular risk reduction. But right now, the Mediterranean diet has the best evidence to show reduction in the incidence of major cardiovascular events in patients who are at high risk for cardiovascular disease. But again, weight loss is whatever diet you can stick to is the best diet for weight loss. So obesity is so complicated. And there's no magic answer, right? Like my patients are always like, you got to figure out how to speed my metabolism. And I'm like, if I knew how to speed metabolism, like I wouldn't look like this either. And it's so complicated. There's genetic influences, there's epigenetic influences. It relates to caloric intake, but it's not just calories in, calories out. It's kind of unfair to our patients when we say calories in, calories out. A lot of it is hormonal based, and the gut microbiome and all these imbalance of signals related to like energy regulation, and use of glucose and stored fats by the muscles and adaptations like that. It really makes a difference. It's not just calories in, calories out. But we know that I don't have a magic fix. And, so, calories out is and calories in is what we're going to have to start with and tell you to do to, eat less calories and burn more calories. And we know that weight loss of as little as 5 to 15% will improve all of these obesity-related comorbidities like development of diabetes and heart disease and all those things. So it's definitely worth it to do it and try and stick with it. And so this chart is a quick summary of recommended of, so how do we treat people with obesity? And basically, and this is from 2018 ADA, but it hasn't changed at all in 2021. And basically, bariatric surgery is recommended for BMIs above 30. And now even we're saying that we're even considering BMIs of like 27 to 29 with other risk factors, but it's paid for insurance with BMIs above 30. Pharmacotherapy is going to be covered by insurance with BMIs 27 and above usually. And everybody should do diet, exercise, and behavioral therapy. So again, like I was telling you about diets, it's like low fat, high carb, none of those things actually matter in terms of weight loss if the only thing you care about is weight loss. And all the popular diets, like all result, and they've like done, I love this JAMA article. It literally head to head compared Weight Watchers, Ornish, Atkins, South Beach diet. And they had the people go on this and every one of them had the exact same amount of weight loss, median weight loss in the end. It's about 77 to 10% of body weight. And like I said, Mediterranean diet is the best for coronary disease prevention, but the key is adherence. And we do have a number of pharmacotherapies on the market now for obesity. I don't have time to get into each one of them, but in patients with a BMI above 27 and comorbid conditions, you might want to consider using these pharmacotherapies. I am just going to say one thing about it. None of these are quick fixes. In every one of the clinical trials of these medications that are FDA approved for obesity, the second that the patient stopped the medication out of the trial, they regained the weight. And those patients who continued on the medication in the extension phases of the trial, they were able to keep the weight off. So this is not like a quick fix. It's not like you can use this and then to jumpstart your weight as much and then you can come off it totally and you're not going to regain weight. It really changes the hormones and the milieu and all these other things going on. And it might not be impossible, but it's really like these are long-term treatments, just like a blood pressure medicine is a long-term treatment and a statin is a long-term treatment. These are considered long-term treatments if you're using pharmacotherapy. And then the metabolic surgeries, there's two kinds. There's the restrictive ones, like the hot one right now is the sleeve gastrectomy, which just limits the size of the stomach. And then the malabsorptive ones like the Roux-en-Y, which literally just take your intestinal plumbing and turn it upside down and make you malabsorb half your food in addition to being so restrictive. And the ones that are The malabsorption ones, you have to worry about nutrient malabsorption. Okay, so you're going to see, I'm seeing now more and more patients who have history of metabolic surgeries, and we really have to worry about, do they have malabsorption of nutrients? And then sometimes people in the early phases after like a Roux-en-Y gastric bypass or gastric sleeve might have a dumping syndrome. Other acute complications, you know, the mortality risk, it's a major surgery. You can have kind of all these things go wrong. And then the long-term complications that we see is some patients just like are never able to really tolerate food without vomiting or having dumping, protein malnutrition, hair loss, gallstones, ulcers can happen, B12, iron, D, thiamine, like all these deficiencies you really have to monitor for. A lot of times the bariatric surgeons give them this like hefty multivitamin that they take, these bariatric vitamins to prevent these deficiencies. Long-term complications are, there is a such thing as a rapid weight loss neuropathy that can occur. Fertility. So rapid weight loss is actually, you know, recommended and improves fertility, especially if people have PCOS type syndromes, but sometimes unwanted pregnancy can happen after somebody loses a lot of weight. They might not be used to preventing pregnancy if that's something that they were not already doing when they were much heavier. Weight regain can occur, and these rare side effects, but again, as an endocrinologist, I end up seeing it, is that sometimes there's so much beta cell hyperplasia in type 2 diabetes or in insulin resistance before the surgeries, then after the surgeries, the cells are still really revved up and making a lot of insulin, and you can end up having long-term hypoglycemia issues after these surgeries. And then I just want to say that, you know, just looking at the surgeries and the remission of type 2 diabetes, the more drastic the surgeries, the more you're going to end up having remission of type 2 diabetes. And it's kind of amazing. It happens like in days to weeks. So we know it's not just the, it's not, you know, like they don't lose that amount of weight in days, but the sugar numbers get better in days. So we know there's definitely something hormonal that changes. It has to do a lot with bile acids and GLP-1 levels and ghrelin levels. But, you know, the bariatric surgeries are a way to improve or put type 2 diabetes into remission. So let's say you had a 19-year-old woman who's referred for evaluation of low blood sugar. For 10 months, she's had episodes of somnolence, extreme fatigue, difficulty being aroused from sleep, and her symptoms usually appear overnight or 3 to 4 hours after a meal, and they're always relieved by drinking orange juice. And findings from her exam are unremarkable, except for being overweight. Her family history is significant, for her twin brother has type 1 diabetes on insulin since age 11, and her past medical history is significant for depression. So during a spontaneous episode of her hypoglycemia in your office, which is occurring 2.5 hours after she ate, these are the lab values you got. The glucose is 38. The insulin level is 25. Normal is 2 to 17. The C-peptide is 0.3. Normal is 0.78 to 1.89. The proinsulin level is 1. And the sulfonylurea level is undetectable. So based on that, what's the most likely cause of this woman's hypoglycemia? Do you think it's A, she has an insulinoma, B, she has factitious use of insulin, C, she has reactive hypoglycemia, D, adrenal insufficiency, or E, growth hormone deficiency? What do you think? Okay, good. You guys remember this and remember looking at the C-peptide. The right answer is B. This is consistent with factitious use of insulin. So just to talk about hypoglycemia. So first of all, you need to meet Whipple's triad in order to have hypoglycemia. I can't tell you how many people have symptoms of hypoglycemia, but if they don't have low blood sugar, documented hypoglycemia, and by documented hypoglycemia, we mean like real low blood sugar, like less than 55 is real sugar, low sugar. Like a sugar of 90 is not hypoglycemia. And in fact, for like a young, healthy female, fasting blood sugar of 60, 70, it might be normal blood sugar for somebody. And they have to have the symptoms, like having like the confusion, sweating, feeling like they're dying. And all those symptoms have to get better when they eat something or administer glucose. So those three things must be met in order to truly say this person has pathologic hypoglycemia. Again, because sometimes people's sugars are low, but they feel fine. Again, non-diabetics. And sometimes they're, they feel like they're dying and they feel better when they eat something, but their sugar, if they actually measure it, is never actually low. This is true hypoglycemia. And just to point out that the lower limit of normal glucose in theory, again, in non-diabetics is about 70. So if your sugar's 70, like if you're in the hospital and your sugar's 75, right? Like the nurse will call your sugar's 75, it's a low sugar. Again, a normal person should have a fasting blood sugar of about 75. Like that is completely normal in a non-diabetic. And then you start to release counter-regulatory hormones when your sugars start to drop 65 to 70. And the counter-regulatory hormones, growth hormone, cortisol, those kind of things. And that's why those options were on my answer choices, a deficiency of growth hormone or adrenal insufficiency. If you don't have those counter-regulatory hormones, that's a cause of hypoglycemia. And then symptoms usually don't happen, again, in a healthy adult until your sugar is down into like 50 or less. And when we try to figure out what the cause is, it could be drugs. It could be like drugs are like the quinolones can cause hypoglycemia, well known that all the quinolones can do it. Pentamidine can do it. Alcohol can end up causing hypoglycemia, critical illness, tumors that are making IGF-1 or IGF-2. Like I was saying, these hormone deficiencies, hyperinsulinism, right? Like a diabetic on insulin or factitious use of insulin. And then the rare, but we always have to make sure not to miss it, insulinomas can cause that. So we always check the insulin, the pro-insulin levels, sulfonylurea, or nowadays it's called like sometimes people call them diabetic agent screens or hyperglycemic agent screens to check if they're exogenously taking a diabetes medicine that's making their sugars low. And these C-peptide levels, while they're hypoglycemic, and you all rightly remembered that if somebody's using exogenous insulin, their insulin levels will be high, but it'll be missing the C-peptide that is made when somebody endogenously makes the insulin in their body, and it goes from pro-insulin, and then we cleave off the C-peptide to insulin. So if the C-peptide levels are high, this is endogenous insulin production from an insulinoma or an acidoblastosis or use of sulfonylurea. Versus if just the insulin levels are high and the C-peptide levels are low, this is exogenous use of insulin. And this is kind of the chart that you all are supposed to memorize. And it seems like you did in order to answer these hypoglycemia questions about the different conditions and what the insulin C-peptide pro-insulin levels will look like. So insulinoma itself, as I said, it's really rare, but you need to remember it's associated with the MEN1 syndromes. And it usually is a fasting hypoglycemia. And in fact, in order to really diagnose it, you're supposed to admit the patient to the hospital and have them do a supervised 72-hour fast. And when their sugar goes less than 55 during that supervised fast, that's when you draw the blood for insulin, C-peptide, sulfonylurea level, pro-insulin to diagnose this insulinoma. And about 20% of patients with insulinoma actually report weight gain because they it just changes. Their mind is always like, your sugar's low, you need to eat, your sugar's low, you need to eat. So they end up eating a lot and actually have weight gain. And it's treated with surgical resection, but we do have some medications that can actually inhibit insulin production from the pancreas. It definitely can be hard to treat. Okay. So any questions about that before I move on to, I'm going to do a little bit of lipids, not that much lipids, because again, like lipids, cardiovascular disease, covered in the cardiology section, but I'll do some of the weird endocrine lipid disorders I'll ask you about. Any questions about insulin, sugar, obesity, diabetes? Yes, and I can look in the chat if you're writing while I move on. Okay, so some of the weird endocrine lipid stuff that we see. So let's say you have a 38-year-old healthy female who's admitted to the hospital with acute onset of abdominal pain. Her only medication is birth control pills. She has no family history of cardiovascular disease or hyperlipidemia, and her labs show a total cholesterol of 458, an LDL of 120, an HDL of 38, triglycerides of 3,000. sugar is 89, and her amylase is 5 times the upper limit of normal. You also check thyroid, liver, and renal function, and those things are all okay. So what's your most likely diagnosis? Do you think it's A, does she have beta lipoproteinemia type 3, the hyperlipoproteinemia syndrome? B, does she have an LCAT deficiency? C, does she have familial hypercholesterolemia? D, does she have drug-induced hypertriglyceridemia? Or E, does she have a CETP deficiency? What do you think? You guys remember your pathways, your lipid pathways, and the conditions that can happen? Causing this lady to have triglycerides of 3,000? Okay, so the right answer, and I'm glad that I put this on if you don't know this is drug-induced hypertriglyceridemia. This is birth control pills. This can definitely happen. You need to be on the lookout for it. Some people are more prone to having aggravation of hypertriglyceridemia and with estrogen. It could be birth control pills. It could be transgender therapy with estrogen, hormone therapy. And it increases the very low density lipoprotein secretion, and it reduces hepatic triglyceride lipase. And you end up having this severe hypertriglyceridemia, which happens, and you stop the estrogen and it doesn't recur. So please take home point on this. I know I'm glad that a lot of you were thinking of the other chylomicronemia syndromes and hyperlipidemia syndromes, but please don't forget that estrogen in a young woman is definitely a cause of severe hypertriglyceridemia, and even a pancreatitis, like in this case, can happen. So just to review our lipid pathways, the chylomicrons are formed by the intestine and are absorbed via the lymphatic system, and they reach the systemic circulation. And the capillary endothelial cells have this enzyme lipoprotein lipase, and that hydrolyzes the triglycerides to glycerol and fatty acids. And then those are taken up by various tissues, muscle, adipose tissue. And you can see like the lipoprotein particle size and buoyancy decrease as a result of like triglyceride depletion through the actions of these lipases. And then like after transfer of some of the membrane like lipoproteins and phospholipids to HDL, then you have these remnant particles that are taken up by the liver via a specific receptor. So what's going on in these like chylomicronemia syndromes is there's a deficiency of lipoprotein lipase. And that can be either genetic, like in the familial syndromes, or it can be secondary to diabetes. Now, diabetes itself causes lipoprotein lipase deficiency. Like we're sure of it, and it leads to a hypertriglyceridemia. And which came first? Oh my God, you could like totally get an endocrinologist to talk about this forever. Not me, but some of my colleagues love talking about, is diabetes really just a hyperlipidemia syndrome? Or does the hyperlipidemia cause the type 2 diabetes? Or does the type 2 diabetes cause the hyperlipidemia? Which comes first? We don't know, but the diabetes definitely causes a reduction of lipoprotein lipase activity. Also, you know, when you treat hypertriglyceridemia, right, we treat with insulin because insulin increases lipoprotein lipase. It's one of the reasons we give insulin for severe hypertriglyceridemia, especially if it's causing like a pancreatitis. Other things that can cause triglyceridemia and a deficiency of lipoprotein lipase is hypothyroidism, severe hypothyroidism, alcohol intake, and dysglobulinemias. So the familial syndromes happen like when the input of the chylomicrons and VLDL exceed the lipoprotein lipase activity, you're going to have accumulation of these triglyceride-rich particles. And a deficiency of ApoC2 is going to present very similarly, as well as the chylomicronemia syndrome, the type 1 hyperlipoproteinemia. In all of these conditions, you're going to have severe chylomicronemia. They'll talk about how the test tube even looks white. It looks almost like milky. It's lipemic plasma. And you can see that around the eyes. You can see eruptive xanthomas, recurrent pancreatitis. There's going to be really elevated triglycerides and chylomicrons and VLDL. And again, this can happen from a deficiency in lipoprotein lipase, which could be, again, diabetes, hypothyroidism, alcohol, or it could be a genetic defect, like as an ApoC2 or a lipoprotein lipase genetic deficiency will all kind of look similar to this, very high triglycerides and lipemic plasma. Okay, let's get into some of the other rare endocrine lipid diseases. So let's say you have a 44-year-old man and he's admitted to the hospital with chest pain for rule out MI. he reports a history of high triglycerides for which he takes fenofibrate. A family history is significant for his father died at age 54 from an MI, and his brother had a cabbage at age 50. And on his labs, he has a cholesterol of 174, an LDL of 100, a very low HDL of 4, triglycerides are 280, fasting sugar is 88, and for him also thyroid, liver, and renal function is normal, right? So we should always check thyroid, liver, renal function on all of our lipid patients to make sure that that's okay. And you do a physical exam and you see this. This is what his tonsils look like. So anyone remember what this is? So the most likely diagnosis is A, Tangier's disease, B, lipoprotein lipase deficiency, C, a beta cytosterolemia, D, an A beta lipoproteinemia, or E, a CETP deficiency. What do you think? Good. Most of you do remember, if you've ever heard of this weird disease, Tangier's disease. I'll talk about it in a second. I'll go through the pathophysiology. Something came up in the chat. Somebody asked, should we screen everybody on like OCPs and estrogen for high triglycerides? And it's probably not cost effective. But again, just to know, there's rare people who have just develop a severe hypertriglyceridemia from estrogens. It seems to be more with oral estrogens than transdermal estrogens. So if there's anyone you're really worried about, like their lipids or pancreatitis or something like that, I tend to use transdermal estrogens. But probably it's not cost effective to screen lipids in anyone who is already not meeting criteria for who you'd screen lipids in, which is probably like age, family history, obesity, diabetes, those sort of things. Okay. So let's talk about HDL. This was like an HDL deficiency. So just to remind you, the lipid poor ApoA and the pre-HDL particles, kind of over here, they acquire additional cholesterol and phospholipids from cells and extrahepatic tissues via this ABCA1 transporter. And this generates particles that are more cholesterol enriched. And so there's this ABCA1 transporter, and then there's this enzyme LCAT. And the LCAT is carried on HDL particles, and that helps esterify the free cholesterol molecules to form cholesterol esters, which then migrates to the core of the HDL particle and forms mature HDL. And so even if you're not going to memorize all these things, the two things I want you to memorize, a deficiency of the ABCA1 transporter or a deficiency of the LCAT enzyme, both which are inherited and can happen, can prevent maturation of HDL and lead to these clinical syndromes, these very low HDL clinical syndromes. So the one I was showing you before is this Tangier's disease, where it's like, if they show you a picture of somebody's mouth and tonsils, like it's these orange tonsils, pathognomonic. These patients can have premature cardiovascular disease, some clouding of the cornea, neuropathies, and the lipoproteins will show low plasma HDL, elevated triglycerides, and a low LDL. And the molecular deficit, as I said, in Tangier's disease is this ABCA1 transporter. Then the other condition can be this LCAT deficiency. So this one presents with severe cloudy corneas. It's called fisheye disease. And they often have chronic renal disease, but no cardiovascular disease. And it will also look very, very similar, low HDL, slightly high triglycerides, but like markedly low HDL. And this is this LCAT deficiency. And this is what this looks like, this corneal clouding fisheye disease that you see. And again, those are the two low HDL syndromes. So it's like if you have low HDL syndrome and somebody talks about orange tonsils, it's Tangier's, ABCA1 transporter, low HDL, and fisheye, renal disease, that's the LCAT deficiency that you're going to have. Those are my lovely lipid questions to show you. The last things I want to show you, and then I definitely want to be able to answer questions, are the Choosing Wisely campaign. I don't know if you guys remember when this came out a couple of years ago, but all of the subspecialty societies were asked to work with the ABIM and come up with a couple like key tips for what you should or shouldn't, it was actually supposed to be like what you should do, but it's a lot of like what you shouldn't do is what it came in, like what is done a lot of times unnecessarily and wastes money and doesn't change clinical outcomes. So the 5 things that the endocrinologist came up with that you should avoid are here. And again, these are things that you should know because they're evidence-based and because these are changes to what a lot of physicians are doing. These things are often asked on exams. So one is avoid routine multiple daily self-glucose monitoring in adults with stable type 2 diabetes on agents that don't cause hypoglycemia. So it's like there's not a point of making somebody check their sugars 4 times a day. And like, there's still those, practitioners out there that are like, and the patients who check their sugars 4 times a day, they have the log books. I'm like, we don't even have log books anymore. They don't exist. They want to write down every single blood sugar. And if they're on like metformin or on an agent that they've been on for a while and it doesn't cause hypoglycemia, there's no benefit of that. It's not going to change their outcome. It's not going to do anything different. You're not using that number to decide on a dose of insulin or anything like that. And again, like the exceptions are if they're ill or if you're worried about hypoglycemia or if their A1C is drifting or you're starting a new med or something else is happening, like you tell them, you want them to have, finger stick stuff at home to test if something is changing, but there's no benefit of actually checking that many times a day. And we know that other countries, during like the austerity measures, like one of the things that happened in Greece was they like literally just did away with glucose monitors for all. They were like, it's cheaper to like do leg amputations than to give test strips are so expensive than to give everybody test strips and glucometers. But again, we don't have to be that crazy about it. But again, so somebody shouldn't be punished by have to check their sugar 4 times a day just because they have diabetes, especially if it's not going to make a change. Okay, then the other thing is the 125D. The 125D is not your vitamin D levels. The 125D is the activated form of D that we only do if we're trying to figure out what the cause of hypercalcemia is. And sometimes the nephrologists do it in the setting of like decreased kidney function. But this, so often I see somebody is like trying to check vitamin D levels to see if somebody needs more vitamin D vitamin. And they're checking this very, very expensive send out high turnover test, the 125 dihydroxy D. Don't do that. You're going to check the 25 hydroxy vitamin D. Okay. The other ones are don't routinely order a thyroid ultrasound in patients with abnormal thyroid function tests if there's no palpable abnormality of the thyroid gland. So I see this a lot. So the indication for doing a thyroid ultrasound is if you feel something, if there's a goiter or you think there's a nodule or you're looking for something anatomic that's there, that's the reason to do it. So often somebody might have like a slightly high TSH and somebody orders a thyroid ultrasound. Or and again, these things don't normally correlate. And the ultrasound thing is become so expensive because 60% of women over age 60 have thyroid nodules that they never knew about. They don't feel them, nothing's happening. And there's this like rash of overdiagnosis. So now you have a thyroid nodule. What do you do with it? Do you biopsy it? Like, do you send them to an endocrinologist? And all this healthcare system costs that are so unnecessary, and only 5 to 10% of all the nodules you find, even the big ones, are going to be thyroid cancer. And the type of thyroid cancer we're talking about is so slow growing that it doesn't matter if you diagnosed it today or 2 years from now or 4 years from now. And nowadays with thyroid cancer, so much of them we're just even leaving in. We're not even doing surgery because people talk about how we're overdiagnosing it and we're costing the healthcare system so much and we're causing so much stress. So we really don't want to know if somebody has small thyroid nodules because we don't worry about it being cancer and it's not going to change the management. So really try to avoid ordering thyroid ultrasounds unless you are really feeling like there might be a nodule there or it's going to change your management. Another one, T3s, free T3s. There's no role of checking T3 and free T3s, especially if somebody's just on levothyroxine therapy. In fact, if somebody's on levothyroxine and you're trying to figure out, are they on the right dose? Do you need to adjust it? We're talking about primary thyroid disease. You really only need a TSH. You don't even need T4s or free T4s or anything like that. And if the TSH is normal, you're done. It's only if your TSH is high or low and you're trying to diagnose disease that you want to see what the T4 is. But there's really no role of T3. T3 is the active form of thyroid hormone. And it's converted T4 to T3 in your tissues. So in the muscles, in the heart, in the brain. And measuring the T3 levels in your blood does not tell me if you are actively converting your T4 into your T3. And so it's only helpful if it's super, super, super high and they have like hyperthyroidism, that's when it can be helpful. But this level is not, you should not ever be adjusting someone's dose of levothyroxine based on a T3 level or a free T3 level. And then the last one is about prescribing testosterone therapy unless they're actually testosterone deficient. And this, like, you know, was a big thing. There was like a lot of direct to patient advertising by the pharmaceutical companies that made testosterone. And they were like, are you tired? Do you have low T? Ask your doctor about testosterone. Ask your doctor to check your testosterone levels. So it's really important that, one, the levels are checked the way that I told you to do it. It has to be 2 times fasting in the morning, and you have to have at least 2 low testosterone levels to even consider testosterone therapy. And then to even like talk about the risk versus benefits, but please don't prescribe testosterone therapy to anyone who's just tired or has low libido, or especially erectile dysfunction. Erectile dysfunction is usually not low testosterone unless it's super, super low testosterone. The erectile dysfunction is usually like, do they have like diabetes or microvascular disease or neuropathy or cardiovascular disease causing the erectile dysfunction and being related to this? That should be worked up, but it's not, an erectile dysfunction alone is definitely not an indication for testosterone therapy. Okay, so that's my little platform on that of what not to do. Any questions or concerns? I have about 5 minutes. Happy to answer anything about what we've done over these 3 sessions. Hopefully it was helpful and you got a good review of endocrinology. Put it in the chat. You can, I don't know if you can unmute yourself.
Dr. Lubitz, I just want to say it was an excellent review of endocrinology. I found the tips on management of DKA to be very useful, particularly on the broad electrolyte repletion and on the importance of starting longer acting insulin well before turning off the insulin drip. I found the lipid review also to be valuable today. Enjoyed hearing about the relative efficacy of the different diets, and also reviewing some of the side effects we need to look for in terms of the bariatric procedures. I think it was helpful to remember that lowering the A1C is not necessarily the key element to reducing the risk of cardiovascular mortality in our diabetics, but rather the importance of controlling the other risk factors. That was I always think of the ACCORD trial, but it's good to put that into context.
Yeah. I'm looking through. I see. So somebody asked about pre-op management and diabetes medicines. So it's a complicated thing. Up to Date actually has a really good section on this, which talks about what's the person's diabetes control prior to the surgery, and if they're on insulin or if they're on orals, and should you hold that, and how long the surgery is going to be and what the risk of the surgery is. So just kind of in general, and usually I think you're referring to like, so other medicines, it's okay to hold off like oral diabetes medicines, because that would, you'd assume that they're not that poorly controlled prior to a surgery. If you want to hold it, it's not going to make a big difference, especially if they're fasting. But like, let's say somebody who's on insulin, they need their basal insulin. I can't tell you how many times surgeries are canceled because they show up in the pre-admission, pre-surgical area. Somebody checks a finger stick, it's like 400, and they're like, did you take your insulin? And then they cancel the surgery. So if somebody is like poorly controlled, and they're, you're worried about them, you can reduce their basal insulin dose the night before a surgery by about 50%. If they're a well-controlled, like type 1 diabetic, you know that their basal rate or their basal dose is actually a basal dose. Versus like a type 2, a lot of times we give a lot of basal because we don't want to use that much mealtime insulin, or the patient's non-compliant with it, or we want to avoid 4 shots a day. In a type 1, their basal dose is usually their basal dose, so they can get away with really close to keeping that dose. Maybe you'd only give about 10% less or 20% less. And again, Up to Date has really good surgery by surgery, medicine by medicine algorithms on how to manage somebody's pre-op medicines. And again, I even look it up with I don't have it all memorized. I look it up often with my fellows. And then somebody was asking me about people who are tired and you want to check their testosterone. Like the testosterone, the thyroid, I feel like those are all things like people are tired, they're gaining weight, they want to look for a hormone cause of it. I think it's okay. I don't necessarily discourage my patients, but if they have, you can ask symptoms of low testosterone besides fatigue, again, which is like low libido, difficulty getting erections, real testosterone deficiency, they're not growing facial hair and they have reduced muscle mass. And you can screen with like an AM testosterone level. That being said, if somebody's using exogenous androgens and products, often their testosterone level might be low and their LH and FSH might be low because they're already using some sort of over-the-counter testosterone product or something like that. But I don't have great advice on that. I end up as an endocrinologist a lot of times checking testosterone and thyroid because it's easy to rule out those conditions, much easier than to convince somebody that it's probably not their thyroid.
Thank you again, Dr. Lubitz. If that's all for the questions, then we want to thank you again very much for presenting to us, reviewing endocrinology in a comprehensive manner. And I encourage everyone to go and get their CME at the link that was provided. You can find it on acpnj.org/education. Thank you again, Dr. Lubitz.
Thanks.